So I can't figure it out, Amber. It came, I hit a button, it's gone, and I don't know how to get it there. Yeah, that's bad. We will get started in just a few minutes, folks. I see people are gathering, and we'll get started in a minute. Okay, I have 12:30 on my clock, but I am gonna wait just 30 more seconds, make sure everyone gets signed in. See, everyone is putting their names in. and that is much appreciated. Hi, I'm Terry Rogers. I almost said my pre-retirement title. I'm a retired behavior analyst. I used to be the chief behavior analyst for the Division of Developmental Disabilities, and it's been my honor to chair this ECHO. I'm very pleased to join you from retirement land today and to see so many faces. This is awesome. This is our 9th Moadd Echo case. And Moadd, just for those of you tuning in new, stands for Missouri Alliance for Dual Diagnosis. And we are a committee of volunteers who are here to discuss some best practices for addressing cases similar to the one that's about to be presented today. Today we have Deanna Kuntz from CHS, who is going to present a case for us. And we've pre-selected this case just for you all to know, based on some characteristics for dual diagnosis that we wanted to make sure that we access different kinds of cases. And we'll have a short didactic at the end of this meeting by Dr. Constantino, and he's going to talk to us about medications, behavioral and physical side effects. So that's going to be awesome. And as I said, I'm very happy to have you all here today. Let me go through a little bit of our agenda so you know what to expect today. I'm going to do introductions for our hub team, what we call our hub team. That's our team of experts who are here to discuss this case with you all and share and learn from you all too. Then I'll introduce the presenter for our case, who will go through some basic information about the situation. And we will then have the team ask some clarifying questions if there are any. And after that, we'll share some recommendations that we would make for any situation similar to this one. During any of that time, please feel free to chat in any questions that you might have or any suggestions or helpful information that you might have, because you all have a lot of expertise also, and we can share that through your information in the chat or your questions and information in the chat. And we would really love to learn from you too. If we have time, I'll call on some of those folks who chat in to share their questions or their informations. And just to let you all know, we are on a time schedule. We all like to talk. And so we're going to try to keep to that time schedule today and make sure we have time for everything. So with that being said, let me introduce the hub team for our ECHO today. And I'm going to start with Amber.
Hello, everyone. I am Amber Stockreef. I am the Interdivisional Children's Services Coordinator for the Department of Mental Health. And for this ECHO, I work as the Clinical Systems Navigator. So all things DD and behavioral health systems and children's related systems.
Great. Thank you, Amber. And Rachel.
Good afternoon, everyone. I'm Rachel Jones. I'm a licensed professional counselor, and I'm the manager of trauma-informed treatment with the Division of Behavioral Health. My role in this ECHO is to help us focus using a trauma lens and thinking about trauma and recovery for the youth and the family.
Great. And Susie. Susie, sprayed you on mute.
Hi, yes, I'm sorry. I'm Susie Henderson, and I'm a licensed psychologist with Borough Behavioral Health in Springfield. My role on the ECHO is mental health expert.
Great. Thank you, Susie. Lisa.
Hi, everybody. My name is Lisa Nothouse. I work for the Division of Developmental Disabilities as the Supporting Families Lead. And today on this ECHO, I am the family advocate.
Great. Thank you, Lisa. And John.
Hi, I'm John Constantino. I'm a child psychiatrist and pediatrician at Washington University and St. Louis Children's Hospital. And my role on the team is to lend the perspective from medications and physicians' perspective on the care of the individuals.
Awesome, thank you. And we have two facilitators from MU who are here with us today. Maria, you want to introduce yourself?
Hello, everybody. My name is Maria Seville, and I'm a clinic coordinator with Echo Autism at the University of Missouri.
Great, thank you. And Robin.
Hi, everybody. I'm Robin Hardesty. I'm also a clinic coordinator here at the University of Missouri. So glad to see all of you today.
Indeed.
All right.
I was just a minute or two late, but unless it's been said already, I just want a special welcome to Mark Stringer, who's joined our meeting today, the director of our Department of Mental Health, and it's an honor that he's with us today. And I have to say that the existence of this Echo and everything that surrounds the initiative surrounding dual diagnosis was only could be possible with his support and his wisdom about prioritizing this. So Mark, thanks for being with us today. There's a special presence here that you're with us on this Echo.
Yes, thank you.
Thanks,
Okay.
John. Hey, and I'm sorry, Terry.
No, that's okay. Oh,
First of all, Terry, never feel obliged to describe yourself as retired, because you won't be. So that's one thing.
I don't seem to be able to not work, so that's okay.
And John has been my friend for many years. And John, thank you for those kind words. I really appreciate that. This Echo, well, I think we've got how many people on the call? On the line
About 30 at the
30?
present.
Yeah.
Yeah.
This will increase significantly over time, and not long time, but near time. We're getting ready to ramp something up with the Missouri Hospital Association. And John, I'm going to invite you to participate in that to the extent you can. I know you've got a tremendously busy schedule, but this whole issue is really ramping up in terms of need and interest and demand, and it's just been long overdue. So I'm really grateful to everybody who's involved here today, and those of you that have started this initiative. This is going to take wings. I mean, it really is, and so great platform, great foundation, and I'm just really grateful to all of you, and again to my friend John. So thank you.
Wonderful to hear, Mark. And it's because of this group that I definitely think that we have cards to play, that we can help the people who are affected by these conditions and do things in a way that will improve lives and reduce disability. And so it's really an exciting time, and it's just a breath of fresh air to hear that this is moving forward, and thanks for everything you're doing. Terry, you're muted if you're trying to say something.
I don't know how I did that. I'm excited about this case today and about hearing what everyone has to say. Deanna Kuntz is with us. And Deanna, is anyone else going to be participating from your team?
I don't believe so. We have a new employee today. So Sean Wade was going to sit in with me, but he actually has been taken away to work on that part. So.
Okay. All right, great. Well, thank you for preparing this case for us today and for agreeing to participate. We really appreciate the case presentations. They help us to do case-based learning, and that's very important in the ECHO process. So without further ado, can you tell us a little bit about this situation?
Sure. Again, my name's actually Deanna Counts, but I've been called everything under the sun, so don't worry about it. So the individual that I'm presenting today is a 17-year-old male. He's Caucasian, and he is in custody. After talking with his host home providers, it was a little difficult to try to pinpoint some specific issues that we wanted to talk about. But the first one that I have found to be probably one of our biggest hurdles for him is that he has very short-term memory. So when we're talking about things of learning how to count from even to 100 or 50, safety skills, social skills, things like that, He can know it one day and the next day you have to start all over again with him. So that's kind of been one of our biggest hurdles. I don't know if that's anything that could ever change though, if that's just part of his disability, but I felt like that was probably one of our biggest issues. And then also looking at social skills, he's a very loud talker and doesn't really understand bubbles, people's personal space. And then he's very trusting, which is concerning to everybody that, you know, that is working with him. And then our other concern is just the safety skills part of it, whether it's knowing who to go to if there was an emergency in the community, going into the right bathroom by, you know, reading the signs, and then just, you know, personal safety as well, because he is very trusting and could be very easily taken advantage of. And just a little bit of history, there is significant trauma, both sexual abuse. I don't know if this individual specifically experienced that, but there was sexual abuse in the home, and there was a lot of mental abuse, of favoritisms, and there was one abuser that was particularly the main person that did the mental abuse. And it was very much like, if you're my favorite, then you get to eat, then you get to have clothes, you get to have school supplies, things like that. I'm not sure just with the his disability, how this really has affected him, but that is a little bit of history in that respect. As far as strengths, he is just one of the most friendly, kindest, caring people. He always has a smile on his face. He's just kind of a joy to be around. One thing that I love about him is, because I have a lot of kids that I've worked with just in my life in general that do not like school. He loves school. He can't wait for the school year to start up a lot of times, and it's just never a struggle to get him to go. And he also is pretty good at cleaning, organizing, things like that. He may need some prompts at times. And then he's a very easygoing young man. As far as strategies that I've used with him, and I talked to the host home provider, and there's not really been anything as far as the things listed that we were able to identify for him. No treatment plans, crisis plans, anything like that. His primary developmental disability is intellectual disability. As far as the substantial functional limitations, pretty much everything but mobility. So all of the other ones are selected with language, self-care, learning, self-direction, independent living, self-sufficiency. As far as his communication ability, you are able to have a conversation. However, it's very difficult to keep him on topic. So he's kind of like that, like shiny ball kind of thing. Like he just kind of, you know, goes off to whatever kind of catches his attention, or if he has a thought come in his mind, that's where we go. So as far as communication, that's where he's at. And then for sensory concerns, we discussed a little bit. I went ahead and put high pain tolerance. We're not really sure. We feel like it's probably minimal, but he did have an issue with two infections in his big toes, and they did have to remove his toenails. And during that time, his host home provider said he really didn't complain much about pain. So that's kind of where we got the idea that he may have a pretty high pain tolerance. As far as behaviors, the ones that were most prevalent that happen pretty much all the time, anxious or worries, has a short attention span, he's hyperactive. Ones that are just sometimes maybe 2 to 4 times a week, obsessive compulsive. And I didn't really get a clear grasp of that. That was something the host home provider provided. I would not have selected that, but they're with him all the time. So, but I couldn't get a clear example for that. So I did want to point that out. And then he does have times where he's defiant. I think that's just normal teenage stuff. And he is food seeking, which I feel like comes from his history with food being kind of a reward. Impulsivity for sure. And then the one that happens maybe rarely or one time a week, property destruction. And I did want to clarify that one. He doesn't do property destruction as far as he gets angry and he acts out and punches walls and anything. He gets curious and he will pick at things, or he will pick something up and not put it down right. Things like that, where he's broke a TV recently, and the host home provider feels like it's because he was looking at the cords or the cables on the back, and when he picked it up and put it down, he dropped it. So it's not necessarily a behavior, but I did want to point that out. He does not have really much behavior as far as what you would say, very typical of a teenager, but like I said, he's very easygoing, and he's just a happy person. With a lot of the assessments, testings, things like that, because he did come into care, he has had probably 2 or 3 case managers since I've had the case, which has been about 2.5 to 3 years. And I believe he had more prior to that. So there's not a lot of history. I think the last psychological evaluation I had was from 2018. So I don't have a lot of information prior to that. So I don't know if functional behavior assessment's ever been done on him, but he really doesn't have behaviors as far as where he's at now. If he did prior to that, we have not been provided that information. And then as far as any significant loss of skills, like I said, the memory thing, I don't know if that's really gain or loss. It's just kind of some days he can do it, some days he can't. Let's see. And I did look at his psychological evaluation. There weren't really other behavioral health issues. I did just highlight that he does have the history of neglect as a child and history of sexual and physical abuse. And then as far as treatment that I have been aware of, he did receive therapy in home with a therapist that also worked with his siblings. So the therapist knew the background, was aware of everything that kind of went on in the home, but she went ahead and stopped counseling because she felt like it really wasn't going anywhere. Again, going back to that memory thing, I feel like she felt like she had to kind of redo everything every time she met with him. Let's see. Again, really the only diagnosis that I'm aware of is the intellectual disability, and that was diagnosed at the age of 14, which was in 2018. And that's the last one that I'm aware of. And he no longer is seeing that psychologist. I think it was just that one-time thing for the psychological evaluation. And then do I need to go through his list of medications?
I think they're already listed on the form as Abilify, Lamictal, and Trazodone, without any history of prior medications, which was a little unusual. Deanna, do you know if it's just not known if he had prior meds, or he never had prior meds, that this is just when he got,
Unknown to me.
Okay.
I did talk to his case manager as well, and she said that she would look through the file because, I mean, they have books on this family just because of there's several kids in the family, and then due to the extent of the abuse, there's just a lot that has gone on with the case. And so I feel like she felt a little overwhelmed trying to go back through and go through all of the history. But she said if she found anything, she would provide that to me, but I never received anything from her.
Yeah.
So, let's see. And then as far as testings that I've been made aware of, he did have an MRI. I was not notified specifically of why that was completed, but he did have an EEG. And at one point he did go to a physical, and the doctor was concerned about a possible murmur. And so they did an EEG, and it came back normal. So there weren't any concerns there. And then
For a murmur, there would have been an EKG for a heart test. But he's never had a seizure before, Deanna, that you know of?
Not that I'm aware of. There's not any history that's been provided to me.
Okay.
Sorry.
Oh, no, that's fine.
As far as sleep study, I've not been notified of anything. Academic testing, I do have an IEP, but there was no academic testing or results provided in that one. But there was information on an intelligence test, and it just showed that his cognitive ability is within extremely low range of intellectual ability. So that was all that I had there. As far as sleeping, his host home provider really felt like he doesn't really have many issues with it. He may have some issues with falling asleep, but once he's asleep, he really sleeps through the night.
Yeah, and Deanna, I would just add, just from the document, just to color in what your great presentation is that his full scale IQ is 41. That will mean something to many of the people in the group. And his working memory was really consummate with that. So this issue of his memory problem, his working memory, you know, that doesn't measure everything about memory, but it was actually in keeping with an IQ of 41. It sounds like he's pretty verbal, though, in terms of his communication and his ability to chat. One way to give the group a little picture of that is if you could say, maybe within the last couple of weeks that you've known him or seen him or whatever, what would be the most sophisticated language sentence that he has said that you could think of that would be kind of typical for him to say?
So he really enjoys Legos.
Mm-hmm.
So he talked to me about a Lego creation that he did. I would say it was very minimal as far as look at what I built or something like that.
But he could say that. Could he say, look at what I built?
Yeah.
Yeah. Okay. Got it. Thank you.
Yep. Again, like I've already said, there is definitely a history of trauma and abuse, of physical abuse, and then sexual abuse. I don't believe it was towards him, but I believe that it was open enough that everybody saw what was going on. And then as far as exposure to alcohol or drugs, again, the parents have not been involved since the current case manager has been involved. So she doesn't know them and wasn't able to give me any information on them. So I'm not sure if there was or not. Like I said, he lives in a host home, and there are 2 other consumers in the home and then the host home parents. So that's all that belong in the home. As far as significant relationships, I feel like with him, it's very much out of sight, out of mind. So there have been very few times since he's lived in this host home where he has mentioned one of his brothers, which I believe is an older brother. And he seems to be the one that this individual has been most connected with, but I can't say that he is a significant relationship for him. Those that he lives in the home with are the most significant for him because they're with him all the time. And then as far as family history, like I said, I don't have any information on the mom or dad. And then of course, and then I don't have any information on the grandparents, but he does have siblings that they all have intellectual disabilities or learning disabilities. And then it looks like there's a brother that did have some seizure history. And then autism spectrum disorder, and then some mental health concerns as far as like anxiety, depression, things like that. But no known substance abuse or anything with the siblings. And then he will be going into the 12th grade. And as far as I know, even just looking at his age, he's not repeated a grade that I'm aware of. He does go to a full-time special education. So he's actually in a certain school district, but then he goes to another school outside of that, but that school kind of covers a broad range of school districts, if that makes sense. But he's there full time. And then he can read, but I think on his last evaluation, which was I think around 2018, they said he was at kindergarten level. So he does struggle in that area. And I apologize, I did not get that selected, but he does have issues with writing as well. But those are all areas that they're working with him on, you know, like trying to teach him how to write his first name, last name, address, phone number, things like that. Let's see. And then the agencies that currently work with him are Children's Division, and then myself as the service coordinator. He does have a community support waiver, and he is receiving community integration weekly. And so I go out to the home quarterly. However, there are other individuals in the home that I see quarterly as well. And so sometimes I'm out there every month or every other month. So I'm able to see him more than that. The way that we communicate, of course, the last year has mainly been either phone, email, or virtual. But luckily, I've been able to do some in-person visits, I think since April. So I was able to see him a couple times. Let's see. And then as far as barriers for the family, definitely time and scheduling, because there are so many siblings that live in different homes. It is difficult, I think, for them to try to schedule times together. And then for this individual, I feel like lack of rapport, just because he's been removed from the home for so long, I feel like he's lost that connection. So it's not really important for him. And even when there is interaction, he's not, it's just like playing with little kids. Like, it's like they're there in front of him, he has fun, but once he's gone, they're out of mind. So I think that's all.
Thank you so much, Deanna. It's hard when you don't have a complete history, and unfortunately, it's not that unusual. So let me see if I can briefly summarize what you've told us. This is a 17-year-old male who's in Children's Division custody, living in a host home with two other individuals with intellectual disabilities. He does not present with serious behavior problems as far as you know, and we'll ask Amber to give us a little more information about why we selected this young man, because we did have reasons for this. He does seem to have some short-term memory problems. He has a history of trauma, both physical, sexual, and mental abuse. Possibly, at least there was that in the family. He's very low functioning, but he can read some words at the kindergarten level, and he does carry on simple conversations. He had therapy for trauma, but that was stopped because the therapist felt he wasn't making progress. And he does have some property destruction history, but mostly kind of misusing or curiosity misuse of items, not purposeful destruction. And he's on some medications, which to me is very confusing, given his lack of diagnosis or symptomology. I'm not clear on why that would be. So that would be one of my questions. But Amber, can you clarify why we selected this young man?
So he had an incident, it's been a year or so ago, in which he touched a young woman in the community sexually inappropriately. So that's one of the reasons he got flagged. There weren't any other incidents since then, but it was one of those concerning based off of his trauma history and things of that nature, along with the psychotropic medications and no real psychotropic diagnosis or behavioral health diagnosis that we saw. He also has an open episode of care with Community Mental Health Center, but you didn't seem to have that listed. So also some concerns about care coordination and if we're having connections with those individuals. So those were some of the reasons this individual came up to us, kind of those system level and also some behaviors that may get overlooked that build to bigger problems.
Yes. Okay. Thank you. I knew there was a reason. So we looked at kids with multiple medications, psychotropic medications, and he came up on that, and he came up on it met the criteria of a significant community event. How long, Deanna, I missed it. How long has he been in this host home?
I want to say at least 3 to 4 years, 3 years, somewhere like that.
And is this the only home he's been in since his removal?
No, he's been in, I want to say at least 1 or 2 other homes. I know he came from a foster home to this one. And I do think there were behavior issues while he was in that home. But again, I apologize. I don't remember what those were, if they were pretty significant or not, because we've just not had any major issues. And I feel bad because I completely forgot about that episode at the pool, but
I'm certain you don't have anything else going on in your life or any other clients. So yeah, you should.
And I have like memory issues with COVID. I don't know.
Well, and
Right.
I think it's worth it to use, the opportunity of this case to think about, what does and does not constitute dual diagnosis. I mean, I think there are things about this young man where some of the expectable consequences of a developmental disability may have been misinterpreted as a psychiatric condition for which he is getting pretty significant medication, psychotropic medication treatment. And so to not really know why is he on an antipsychotic, why is he on lamotrigine, why is he on trazodone, is that, I mean, part of the discussion may revolve around that. And Deanna, I think getting to the heart of that and understanding the history of that, and then, thinking forward about the things that are also right now troubling you guys, like, why can't he remember? Why can't we train him? Is he untrainable? Are there things, that we can do to help him, build up his repertoire, especially if he's a good-natured young man, and that we want to, give him every opportunity to make his contributions and adapt to his life. So anyway, I think, there's plenty to talk about here, and we'll kind of go through the process.
Yeah, and Deanna, don't feel bad when we ask you questions. What we're trying to do is model how we would approach a similar situation in terms of assessing the problem. And we would very much approach it in a team-based approach with lots of different team members. So it is not on you to know or do everything, okay? So we just want to maybe highlight some questions that you might bring forward and some issues that you might try to find out about, and then some suggestions for folks. And it's not unusual to have a situation with a children's division child where we don't have all of the information. So that being said, I'm going to open it up to team members, and I'm going to start with Rachel because my ears pricked at a couple of things, and I'm sure that they did for Rachel too.
Thank you.
Hey,
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 Deanna.
Rachel. I'm sorry. And Terry, I'm eager to hear what Rachel has to say too, because I've got a tremendous amount of respect for her. And I was watching the looks on her face during this presentation. And Deanna, that was a masterful presentation. So thank you for that. And I'm going to point out the obvious to the people on this call, whatever it's called. Sorry, I'm old. I have no idea what this is called. A WebEx or something like that.
Yeah.
So, but what this points out to me as much as anything is that there's been no consistency in this person's care, and that's my fault. That's my fault. we don't know what happened to this person. We don't know if he's had a history of seizures, which that was a spot on question, John. I mean, we don't know that. We don't know why he's on these meds. And that's because there's been no consistency with care. And so, as I always point out, in Fulton, for example, at Fulton State Hospital, where we hire people at a starting salary of about $11.83 an hour at Fulton State Hospital. And it's not that different in our community providers. And yet, the Dollar General Distribution Center in Fulton is hiring that it will start people at $15.50 to $17.50 an hour, plus a sign-on bonus, plus benefits that are better than ours. Mm-hmm. And I'll bet you at the Dollar General Distribution Center, you're not going to be slapped or spit on or hit or whatever. So we can't compete with that. Now, the good news is that we have made this pitch, and this is thanks to people like Nora Bach, who's the director of the Division of Behavioral Health, and Val Hoon, who's the deputy director now, and will be my successor at some point, and people like Jess Bax and Molly Beckman and Sarah Murphy and others. We are making a full court press on this issue of how we pay our staff, and what a difference it would have made in this young person's life if there had been a consistent caregiver. We can't imagine, but it would have made a huge difference. But we can't keep those folks. So anyway, that's my soapbox. But I will again, and I'm sorry, I'm going to sign off here before too long. But I'm going to present this echo to our cabinet and the governor's office, and not just suggest, but insist that those of my cabinet colleagues who have an investment in this, including the Director of Social Services, Jennifer Tidmall, whom I truly admire, the Director of our Department of Corrections, who is a friend of mine, and others who have an investment in this. Let's get on board with this and let's figure out how we can help. Yeah. So that, I think, is what I have to say. Sorry for interrupting.
Mark,
go ahead.
Thanks very much. I think the insight around the root cause of some of these discontinuities is so important, and it's so important to have a way and a voice to understand what the implications are for that in an individual life. So thanks for bringing that up. Thanks for fighting for that. I would say too that if you can only get the salary to $14 an hour, but not instead of 16, or they only go so high. I think the other side of this is that there are these very dedicated people like Deanna and others that are in the field and in the trenches, and if we can aid them with the mechanisms for information transfer and sharing and communication, that's part of it too. Part of it is the personnel, but part of it also is just moving the information in the information age. It's 2021. And so I think, we're going to have some exciting opportunities for how to carry forward the right information for the patients and to arm people with the knowledge of what's possible for the patients. And that's kind of our task here, is so that everybody can know what might be available to look under the hood and improve the life situation for these patients. But thanks very much for that insight and input.
Sure, John, and you are absolutely right. I'm sorry, Teresa, Terry, forgive me for this, but yeah, you are absolutely right. Right now, if you transfer from one region of the Division of Developmental Disability, to the other, you will be followed by boxes of records, because there is no electronic record system. Now we are getting that changed, but it has taken years and years to get it done. Yeah. And that's a state problem. But anyway, we will address that. But yeah, the technology is critical. We have people, and this is the last thing I'll say. I'm sorry, Terry, but this is we were talking to the governor's chief of staff about this the other day, and said, and he said, this, where you're going to start with this pay plan for your employees and your providers is not going to be enough. And he said, but you know what else? This is doable, and it will give people hope that there's something on the horizon. So I think, and it will give people hope, I think. And we have people who like Deanna are just committed public servants, who really care for these people, for our people. And so we will do what we can at my level. I promise Dr. Constantino has been a constant support for this kind of stuff. So we'll make things happen. I believe that. So
Yep,
Carrie,
no-
I will shut up now.
No giving up.
Yeah. So one of the things just to highlight is it's not just information sharing within the division. Every agency that's involved.
Across the disciplines.
And yeah, so this is a pretty usual situation, not unusual situation. So we want to highlight some things that you should pay attention to and take back to the host family and the children's division worker also. So Rachel.
Thank you to everybody who's commented so far, highlighting a lot of systemic areas where we can improve. Deanna, you did a fantastic job presenting the case. I especially liked your strength-based approach and talking about all the things you love about this young man, his skills, his ability. That was awesome to hear. So I have some clarifying questions just from the trauma angle. The first is, to your knowledge, when he was receiving the trauma-based therapy from the provider who discontinued right before the pandemic, was that to serve him individually for some anxiety or trauma reaction? Or was it for the entire sibling set because of the family-based trauma exposure? Do you know?
I want to say now that Amber had brought up the issue at the pool with the inappropriate touching, I feel like I'm thinking that maybe that had something to do with it. But I feel like you guys are probably more aware of this than I am. I feel like when we have kids that come into custody, there's like a cookie cutter way of handling it. And therapy is one of those things they have to do. And so I feel like sometimes for him, he hadn't had it for a while. So this children's division had put that back into place. And I think she was trying to work with him on appropriateness. But I'm not 100% sure, but that incident did kind of trigger a little bit of information for me. So.
Okay, thank you for that. So that was my next question, was a little bit more detail about what was the outcome of the incident? For example, was law enforcement involved? Did the person who was touched report something? Can you tell us anything about what actually occurred as a result of it?
I really can't remember. I know that if I remember parts of it, they were at the pool, he touched an individual, and I believe that person's father was there and made a point of saying he did this, and he was with a staff. They were out on community integration, and I think that staff was able to kind of step in. I can't remember. I feel like just because there was inappropriate touching, I don't know if that staff or the individual's father called in a report on it, but it was reported just because of the inappropriate touching to a child, I believe.
Okay, so I think
like it kind of handled it there where, that's not okay for you to do that. I feel like they kind of handled that there. I do not believe law enforcement was involved.
Okay, thank you for that. And I did also want to know what the age was. I think Amber referred to her as a young woman. So I didn't know, were we talking about he touched an adult, but it sounds like maybe it was a child under 18 at least?
Yeah.
Okay, thank you for that. Then just a couple other questions that I don't know if you mentioned, but I'm curious about. Is he physically active? Sounds like he likes to go to the pool, but does he engage in physical activity, especially to help manage anxiety or the distraction and things like that?
He's in a home with 2 other boys or young men, and they all enjoy playing basketball. They play soccer together, throw the football. They have a foosball table. They have a little basketball thing and downstairs in the home. So I feel like they do. And I know when he's at school, they play basketball things too, because I've gone to see him there and he's come from playing basketball.
That's
I know he
great.
is a
Okay.
fan.
Yeah, that's wonderful to hear, especially with all those meds, which someone else can talk about. But I worry when someone's got all the medications that then, you know, that physical health side and then activity becomes more difficult, or they're just not interested in it. So that's good to know as a protective factor for him. And then my last question, can he remember lyrics to songs?
That's a good question. I do not know that answer. I can find out, but I don't know.
Yeah, I think someone mentioned kindergarten level. And so I'm thinking a lot of kindergartners learn about safety, about how to be with other people through song. And sometimes people can actually remember words to songs a lot better than they can remember things that were taught to them in a different or more traditional way. So that's why I was curious about it, and it might show up later in my recommendations. All right, someone else's turn.
Okay,
Hey,
just
John,
wanna
I'm
highlight-
sorry. I'm sorry. John, what's your reaction to that? That's a fascinating question she was asking there.
So I think what I was going to say and would follow on Rachel's comment is that this young man is capable of learning something. And he's learned many things. He's learned how to talk. He's learned partially how to write and read and so forth. And the problem is right now that you're trying to train him, and it seems like it's all slipping away. Like he never remembered it in the first place. And his working memory is low, but not non-existent on the basis of his testing, unless something has happened to him since the testing occurred that would, box his memory selectively for something, which is very unlikely. So what I'm thinking about, Deanna, is that the question that Rachel prompted, I think probably should blossom into really a wholesale inventory of what has this boy learned. And he loves to learn. He loves to go to school, which is an advantage. And I think there's things that he is going to be capable of learning and mastering, and other things that are just going to be gone and that are, thinking about his developmental level and so forth. And we have to start categorizing what it is that he can, capture and retain and put into play and, actually, functionally negotiate and hang on to. I think part of this too is the question of whether or not he has superimposed ADHD, which many of these syndromes do. And if that's the case, part of the problem with him not remembering is him not attending, even though he kind of looks like he's attending, but he's super distracted in ways that you don't even know. But if we don't know how distracted he is, or if we don't treat that, then there are some people with comorbid intellectual disability and ADHD that are so distracted that it's impossible to learn until you treat the ADHD. And you could even pre-treat certain situations where you really want him to learn and really want him to be on, to be, have a medicine on board that would help him to retain that. Like there are precedents for that. So I won't get, I'll wait my turn, but that's my answer to Mark. And I think that would be my follow-up to Rachel's comment.
Yeah, John, and I'm sorry, guys. I don't mean to dominate this conversation, but John, you are absolutely right. As the father of a son with severe ADHD, you are absolutely right. So thank you for that comment. And so I'm sorry, Rachel, go ahead, or whoever. Terry, go ahead. Sorry.
Okay, so we have about 8 more minutes left for our question section. So I'm going to suggest a couple of things. First of all, let's prioritize the information that you want to hopefully highlight for Deanna to get, or hopefully that she can give you. But also, if you have multiple questions that are just things you'd like to know and not maybe urgent, that you put them in the chat so that one, Deanna can see what we would ask about, but two, that everybody else can see the kinds of things that we would ask if we were in this situation trying to help this young man directly. So I don't want to lose the question or the discussion opportunities, because we learn a lot from the questions that people ask. but I do want to make sure that we get to the recommendations and even more importantly, the didactic, because we all want to hear about the behavioral and physical side effects of medications. So that being said, I'm going to go to Susie.
Harry, it's really hard to limit. So let me say this. This isn't a question. This is a throw to John, maybe when he talks in a minute. A couple of things. Sometimes medication affects our memory if we're over medicated or under medicated. The other thing is anytime that I am working with a kiddo who seems to lose things that he knew yesterday, I always wonder about seizure activity. And so, John, if you wanted to talk a little bit more about that when it's your turn, because you'll have answers, I just have questions. And so the thing that I guess I was interested in is how you talk about him being anxious. Let me first say, Deanna, thank you. I loved your presentation. And the thing I probably loved the most is you knew this kid, you know this kid, and you like this kid. So thank you for sharing with us, sharing your heart with us today. So when you say anxiety, tell me what that looks like. What makes you think that he is anxious? Why do you use that term?
That was part that I really went through with the host home provider. So I don't feel like I could probably give you a great example. Things that I feel like I'm trying to think. I can't recall anything right now. I want to say I almost feel like they might see it anxious or worries when he has this like excess energy where he might seem worked up or something about things, where they might see that more as anxious when it's just he needs to burn off some energy too. I don't know. So
okay, thank you, Deanna. I have more, but I will pass it on to the next person.
Well, like I said, if they're kind of more instructional or things that you'd want Diana to think about, please put them in the chat because we'll all learn from them. And if it's things we need to know, then we should ask them. Let me see, Amber.
Thanks, Deanna. Again, great presentation. Just want to echo. Didn't mean for that to be a pun, my other colleagues. But my question revolves around coordination with the other entities. So how often would you say you're in contact with the children's division worker and other providers who are around this individual?
I really don't have much interaction with the children's division worker. There are times that I have tried to schedule my quarterly contacts when she's going to be at the home, or have invited her to come to the annual ISP meeting, and either I don't hear from her or it's not going to be able to work with her schedule when we're able to work that with everyone else. So my interaction with children's division, I want to say I feel like it's been more than some people have, because I worked for children's division for many years. And so I don't have as much grace for them probably as some workers do. I push and I'm kind of I hound them until they get back to me because I know they're busy, but I still need answers and I still need information. So, but there's not a whole lot of coordination.
Okay. This kind of plays into this. My last one is, so you said this was like his third case coordinator or children's division worker that you've seen at least. Mm-hmm. Are they from the county that this child resides in, or are they on the other side of the state or further away?
They are not local.
They are not local.
I'm really not good at, I can't even remember what county he's out of. But I don't think it's close.
It's not close. Okay. And that's all I have right
now. Okay. Well, I can't type and ask questions at the same time. So I'm wondering, when you say short-term memory, I'm wondering about head injury, especially with the history of potential physical abuse. And I also worry about the medications and are they affecting memory? So those are two things that I would worry about. And I'm fairly certain you don't know about the head injury because it happened likely when he was living at home. So, but that's something that I would wonder about. I'm pretty concerned about somebody with no, I'm going to put it in quote, behavior problems and tons of medication. So I'm wondering why, here, these are questions for you to maybe ask or to help get follow up on, but how long has he been on them? What originally prompted somebody to prescribe them? How often are they monitored? Is it time to look at those again? Because it will affect his functioning. It will affect his learning. So medications can affect learning. Medications can affect how you respond to reinforcement or rewards, which is learning. They can affect memory. There's a lot of things. I'm not speaking as a physician, but I'm speaking as a behavior analyst who studies the effects of medications. And so you want to be a little bit worried about somebody who's on medications. The other thing that I'm worried about is—
Carrie, I would like to clarify really quick. The information that I have is just from one psychological evaluation from 2018. So I may not have the current information, but that will be something that I will follow up on to make sure I do get that.
Yeah, excellent. The other thing that I'm wondering is, I understand the need to be able to write your name. I'm not certain that's the most important thing for the school to work on, given some of the other stuff that you've said. So I'm wondering, what else have they tried to teach him? Are they working on social skills, which they very well could be and should be? And are they trying to address some of those more functional life skills, like safety skills in school? And if not, could this be something that we can supplement through our waiver services? So those are the questions that I would have. And we're only 3 minutes past my scheduled time for moving on to recommendations. So yay for us. So recommendations, everybody. What would you recommend that Deanna help the team that's serving this young man? And so also everybody, these are recommendations that we would make in any similar situation. So Amber, let's go with you.
Well, you would go to me first. So my recommendations are, I know you've been really trying to reach out to Children's Division, but it's really difficult to plan for this individual's future when we don't have that care coordination and knowing like what are those next steps. Plus, as being the guardian, you kind of have to sign off on things, especially if we talk about, or if there's going to be recommendations of looking at psychotropic medications and so forth. Having them involved is very important.
Yeah, Amber.
Yeah.
Hey, I'm sorry. I will sign off after this. I'm sorry.
No,
this has been a
fine.
fascinating conversation, but this is where, and you put some great things in the chat, and you're asking the right question. But this is where bureaucrats like me and experts like Dr. John Constantino can come into play. If you have trouble with other state agencies cooperating for whatever reason, let us know, because we will not solve this on a systematic basis. We will solve this on a case-by-case basis. My friend Dr. Joe Parks always said that. You don't change a system with a sweep of the hand. You change it on a case-by-case basis, and we have seen that happen. And John and I have both seen that happen. So let us know. John will contact me directly, or you contact me directly. Anybody on this call, when you have a case like this, where there is whatever kind of roadblock, let's solve these on a case-by-case basis. The good news is there aren't like hundreds of thousands of these. There are too many, but there aren't hundreds of thousands of these right now. So let's work on them on a case-by-case basis and work things out. So that's it. Sorry, John. Sorry.
Such a great invitation. And I think, that's part of the ECHO method too, Mark, is that the whole ECHO method was designed to disseminate knowledge one case at a time, and based on really drilling down and getting an understanding of what the problem is and what needs to be learned. So we're really happy that everybody, is on this virtual call, and that this learning community is getting its legs and getting established, because this is the way that, that learning happens too, is to really talk through these issues in individual patients.
Yep.
Great.
Thank you. And now I will sign off. So
No,
thanks,
you're
everybody.
fine.
Okay. Bye.
Amber, do you have anything else? So find information, coordinate with Children's Division.
Coordinate with Children's Division. Also, he has an open episode of care with a local community mental health center in your area. I'm trying to find out if you can, you're going to have to work with Children's Division, of course, guardians releases and things like that. But
Right.
why he has an open episode of care, I don't know if it's medication management or if he's actually receiving services. If he's actually receiving services, it'd be kind of interesting to see what they're providing. Also, too, with medication management, also trying to talk through some of the recommendations we'll probably have around that. And just planning for his future. He's 17 now. He's going to age out of Children's Division in 4 years if they don't relinquish custody sooner, because he's doing well. And we need to have a plan for, where he's going to go, what he wants to do, where he's going to live. The host home provider seems to be doing well compared to past placements, but he may not want to live there. He may want to live somewhere else. So those are all questions to consider and talk through in planning for this young man.
Okay, great. Rachel?
Deanna, I think my top 2 recommendations are to get the mental health diagnosis information a little more clear on his specific trauma, like what that trauma therapy was, whether it was for him or a whole system, a whole family system. My second recommendation is to try to use some learning strategies like music or little pocket-sized social stories, images of him knowing the difference between the men and women restroom, like you mentioned before, and who would he call? What's the number? Something he can have easily that he can put on his person every day, so that when he's out in the community, he can pull that out, and that can hopefully provide him a real-time guide, because I know that safety in the community piece was concerning to you all. So I think those are my top 2.
Okay, great. Thank you, Rachel. Susie?
I'm sorry, I can seem to never unmute. And so I think my top 2 is medication, is just to have that medical evaluation to determine what is the appropriate medication, if any, for this kiddo, as well as looking at any other things medically that may be going on with him. And then the other is I too, as Amber said, I'm really concerned about his age and the fact that he's in custody of Children's Division and what's going to happen next. And so I think it's really important to start that plan immediately, so that one day it just doesn't happen, and then what does happen next for this kiddo. So those are my 2 biggies.
Great, thank you. Lisa, any recommendations?
Yep, I'm getting them typed up. I put my questions in the chat box, and I finished one little sentence, and I'll send you my recommendations there, but I support the medication situation as well, looking at that first and get that lined out. But then also the family really working closely. If it's working at school, there's got to be things that they can replicate. And just like Rachel said, whether it's a picture book, something that keeps him, you said he was organized, liked to organize. So a picture chart with different things, and making sure that they're consistently teaching and following even what the school is doing. Sometimes it's even the verbiage. If the teacher's saying something to get a response and it's working, then the family needs to be doing that as well. So making sure they're really tied in with the IEP and the school staff and following some of the same things. Thank you.
Okay, great. Thank you, Lisa. John?
Yeah, echoing that, I think, and also corralling some of the information from the chat from other members of our learning community here. Deanna, I think, making sure that you get whatever help is available to systematically leave no stone unturned in figuring out what is the inventory of what this boy can do and how do we double down on what's possible for him. I think that's a really kind of recurring theme to think about as he's approaching adulthood. What could he retain? And so I think that and how to fashion that kind of strategy for him for future learning is just so important. And I really want to echo with that. And it could be a behavior analyst that can help with that, to do functional assessments of his behavior and including what he is capable of mastering, overcoming, learning, retaining, all that kind of stuff. But I think there's people in other disciplines that could do it too. But and just start with your own team. But I think take a serious inventory about those opportunities for him to learn is very important. And then I'm going to say something different that I think, I echo all the medication stuff, and I want everyone to think about, whether he's been treated for ADHD or not, because that could really be a game changer for this young man. Oftentimes we don't think about that condition in people who are developmentally disabled. And so that's something, but I'm going to say a different thing. So I'm kind of overusing my 2 points, but he needs to be genetically tested. Okay. His family is riddled with developmental disability. This is an inherited dominant developmental disability syndrome. Okay, that is running through his family and is going to continue to be perpetuated, that, whether by him, whether by other family members, in a way that if we can help the family to know, what is, holding back cognitive development, memory, all of those things. These are things that we could, get at the next generation, or also assist with other family members, or also trace back to the chain of causal events that led to his, being in children's division custody in the first place, if his parents are affected, all those issues. And all it takes is to get one of the family members and specify what the genetic cause is. And we are in the genomic revolution now. It's possible to do that. So we would be very glad to help at WashU to make sure that can happen, from a clinical standpoint, if that's what we need to do. That needs to happen. It doesn't sound like it has.
Okay. Thank you, John. And my recommendation, in addition to all the other stuff, of course, is to think about, when you're thinking about planning for his future, I know it seems like he doesn't pine for his family or miss his family, but depending on what happens with him in the future, there may be no consistent person for him without family, right? So let's say the host home says, yeah, thanks. We don't want to have anyone over 25. And so now he goes someplace else, and, staff are not permanent. You're not permanent. You're going to move on. Who knows him? Who is his family? Who cares, not just cares like it's my job to care, or I work here because I care, but like, has a personal relationship with him. And so I would try to work on maintaining contact with that one brother, at least, that he seems to care about. That would be something that I would worry about in the future. And so that would be one of my recommendations. And we will give you all of our recommendations. If you want, I'll copy the questions to also give to you in case you want to try to follow up, or and really get other people involved. It's not all on you. So you need a team here, girl. And see if you can get some good help for this young man who maybe could go much farther than people think. So that being said, we're right on schedule for the didactic, John.
Okay,
Tino.
I'll share my screen. I'll just say parenthetically to add to what Terry said, Deanna, one of the great things about this case is this boy seems happy, adjusted, and is not actively acting out. And in that situation, in the setting of a, disrupted home, and you guys providing this care to him and so forth, there is a lot of things right with his life right now. Like, this is a great situation that he is adjusted and happy and smiley and, enjoying going to school and so forth. So a lot of things are happening right. Please don't take this as criticism, but you brought his case in good faith to the group to brainstorm about what else we could be doing for him. And in that spirit, I think that's how all of this is rendered, for all of our clients within the system. We're always looking, again, to leave no stone unturned for how can we help and how can we support their best outcome. So thanks for the case. Thanks for taking such good care of him. And thanks for, really bringing this set of issues to our attention. So it's really, really very good. Okay, I'm going to share my screen if Maria lets me. I think I can. Let's see here. I need to bring up, 1 second. This is always tricky. All right. Have to get the right. I'm going to. Oh, was I sharing my PowerPoint? There it is. Okay. Now I'm going to slide 1. Okay, can everybody see slide 1? Are we on the same page? So adverse effects of psychotropic medications commonly used in dual diagnosis. And the side effects are many and the minutes are few. So what I like to do is organize these kinds of talks into big parcels of what we would want, everybody to know. And hopefully this isn't all duplication of what folks already know, but I like to organize it this way, and hopefully everyone will get a little something out of this short presentation on what is a very big question. There's lots of meds, there's plenty of dual diagnoses, and there's plenty of side effects. And so how do we think about those from a clinical standpoint and arm all stakeholders for people with dual diagnosis, how to think about those. Here's my speaker disclosure. I get royalties for the social responsiveness scale, which we developed to measure quantitative autistic traits in a very efficient and inexpensive way that's available to the community. And these are the objectives of the Moadd speaker series. Last time we presented the Moadd mobile app. I want to remind everybody to go to the App Store, pick it up. These are some of the key screens from the app that lead the user into our decision support process for how we think about dual diagnoses, recognizing this, ensuring the patient's safety, considering all the biological and medical factors, the psychological and social factors, and then deriving an approach to the support and care of an individual, leaving no stone unturned by really considering all of those aspects. What dual diagnosis are we talking about? What safety concerns do we have to honor? And how do we address biological, psychosocial, and trauma-based factors, and really put the whole package of care together for these individuals? The app walks you through all that. So we really encourage people to check it out and give us feedback. There's an email address for feedback for the app, and we want to make it more and more and more useful to our users. Last time I talked about the use of psychotropic medications in dual diagnosis, and we said that one of the most important things that we are doing is to address the comorbidities, which include ADHD, as was talked about today, mood instability, aggression, mental disorganization in times of stress, anxiety, insomnia, and comorbid elements of obsessive compulsive disorder. These are major sort of playing fields for the use of psychotropic medications. And we talked about the different psychotropic medications that are used to address those principal comorbidities, because the developmental disabilities themselves are not yet treatable by medication treatments, but psychotropic medications are usually used in dual diagnosis to target one of these domains of symptoms, and can do so very successfully when used to advantage. Now, in order to talk about the issue of adverse effects, you have to think about what does that mean in terms of medication classes. So what we're talking about, again, we talked about this last time, are the stimulants, the alpha agonists, the antidepressants and anxiolytics, which are in various drug categories, and the mood stabilizers. And so we covered this slide last time, I won't belabor it, but each of these classes of medications has its own kind of side effect profile. And we could spend a long time talking about all the various side effects of all of these medicines. But what I want to do today is corral the information on side effects into something which I hope will be useful, which is to begin with life-threatening adverse effects. Because when a medication is being used, what you'd like to know is for your loved one or for your patient or for a client, or if you're a stakeholder, that if a patient is using medication, you want to steer clear of life-threatening adverse effects. And if you can't, you want to know when they're occurring. And so the major life-threatening adverse effects, and people don't always think about all of them, okay, that are of reasonable frequency with the psychotropic meds include anaphylaxis, which is a whole body allergic reaction that results in cardiovascular instability and a sort of a crisis of, a life-threatening crisis of the stability of the cardiovascular system that is based on an allergy. So this is the whole thing of, like people who are allergic to bee stings or peanut butter or whatever, where, if they are allergic to that medication, it's one thing to have a drug rash, it's another thing to have anaphylaxis, and that can happen. And everybody needs to know about that when a new medicine is being started. A patient can have their first episode of a particular allergy to that medication. We try to avoid that, but it's always something that one has to think about when using a medication for this purpose. The second one we talked a little bit about last time is neuroleptic malignant syndrome. Neuroleptic malignant syndrome is unique to the class of antipsychotic mood stabilizers, which again is this group: Abilify, Geodon, Risperidone, Invega, Haldol, Clozaril, Zyprexa, Seroquel. There are other names for those. That is a group of medicines that when an individual is started on these medications, there's a black box warning within the FDA guidance on the use of this medication that they can all cause neuroleptic malignant syndrome. And neuroleptic malignant syndrome, what you really need to know about it is that it is, again, a syndrome of collapse of the usual systems that maintain homeostasis, both neurologically and cardiovascular homeostasis. And so what happens in neuroleptic malignant syndrome is people are sick looking, they're obtunded, which means that there's a significant change in their level of consciousness. They look and feel ill, their blood pressure is dropping, and it is an emergency. Okay, when that is happening, when a patient has started in the kind of near term of when a patient has started one of these medications, it is not a common adverse effect, but it is a known adverse effect. And if it happens, you have a matter of minutes to hours to get that patient to an emergency room for stabilization, and a significant number of them will die of this. Okay, and so the survival depends on how fast you get to the emergency room. So it's very important for people to understand, again, even though these adverse effects are relatively rare, that you have to know about them, and you have to know, what to do if you're seeing signs of them. And I really want to emphasize these particular adverse effects, because sometimes they get lost in the shuffle. Oh, well, the patient can get, a little bit of Parkinsonism, and they can get neuroleptic malignant syndrome, and they can get a rash, and they can have dry mouth, and they can have urinary retention, and their vision gets blurry. Which one should I know about? This one you should know about. This is the most important thing that you have to know about, and know when to act upon that. Luckily, that one's relatively rare. For the same class of medications, we talked about this a little bit last time, tardive dyskinesia is one of the most feared longer-term adverse effects. And the reason I say life-threatening is that it is life-threatening in the sense of it can be so disabling and so irreversible that I put it right up there in terms of quality of life-threatening. Because tardive dyskinesia, which is a syndrome of involuntary muscle movements that once they start, they can become irreversible, can be so disabling to a person that we really try to avoid them. And the reason why I bring that up is that when patients are on antipsychotic mood stabilizers, they often get left on antipsychotic mood stabilizers as they transfer care. And then the assumption is, and this is an assumption probably in Deanna's, clients' cases, well, if somebody else put them on this, I got to keep them on it. And then the next person says that, and then the next person says that, and then they're on an antipsychotic for 10 or 20 or 30 years when they might have only needed it for 6 months or a year or what have you. And this is why I think you're hearing this refrain from the group of make sure you know why, because tardive dyskinesia creeps up after 1 year of use of antipsychotic mood stabilizers. At any time it can start. And what I'm going to do is I'm going to try to share a little video of what that looks like, because a lot of people have never really seen that. And let me see if I can just pull it up here real quick. If I can't get it right up, then I will, I'm going to stop share and then find this video here and then reshare. And let's see if this will come up. Okay, here is a lady with tardive dyskinesia. Okay, and what this is showing is that the very earliest signs of tardive dyskinesia.
Notice this patient's blinking. Try not to be distracted by the other facial movements.
And so these are the earliest warning signs of tardive dyskinesia, that these subtle orofacial movements often. And this is a person that's doing an Ames test to describe exactly how to carry that out. But these are the kind of movements that we're looking for in tardive dyskinesia. And when they start, you want to address that. There are ways to stop it, to try to reverse it early in the game. And that is something that we definitely try to do because, hang on one second, let me just stop that video real quick. That's something that we try to do because they usually from that point just simply progress, and we don't want them to progress. We really want them, to be caught at the earliest stages and then to treat them. And sometimes the only, and best treatment is to stop the medication and try something else. Okay, so back to our life-threatening adverse effects. And then Stevens-Johnson syndrome, I talked about this a little bit last time, which is unique to tegretol and lamotrigine particularly. And this is a situation where you actually get an inflammatory response. It's a little bit like an allergy, but it's a particularly nasty kind of drug rash that involves not only your skin, but every mucous membrane in your body, including your intestinal lining and all the mucous membranes. And so if this really takes off, it can be fatal. And the sign for Stevens-Johnson syndrome is what's called a target lesion. So when you go to Target and you see the red and white rings of Target, okay, that's what happens in Stevens-Johnson syndrome. So when a patient with on tegretol or lamotrigine develops a rash and they have little targets on them, get them to an emergency room now. And again, these are, not super common, but they are the most important thing. And I think if you have a good knowledge of what the life-threatening adverse effects are, how to notice them, how to head them off at the pass, get the patient to the emergency room, or in the case of tardive dyskinesia, observe them for the earliest signs that this could, turn from, lip smacking into a complete whole body contortion to where you just can't even control your own movements, okay? These are the things that we really want everybody to know about and concentrate on within the broad sea of side effects. Okay, so that's the first layer. Second layer is serious, irreversible adverse effects that aren't really life-threatening. And so again, I put tardive dyskinesia in both of those categories because in some ways it's not exactly life-threatening, it's life quality threatening. But tardive dyskinesia and diabetes and cardiovascular disease are the things that we think about that are really things that can crop up with the use of psychotropic medications over time. And once they start, there's nothing you can do about them. Okay, so we talked about tardive dyskinesia. The issue with diabetes is that all of the cardiometabolic risk that's incurred by the medications that cause weight gain can result in syndromes that result in diabetes or very serious cardiovascular disease, risk for heart attack and stroke and so forth. And once those risks start to accrue, they're with you. They're very difficult to undo. And so, especially for patients who are showing the early signs, monitoring blood sugar and monitoring weight are extremely important for patients who are gaining weight, on particularly on the antipsychotic mood stabilizers, but other mood stabilizers can do this too. And the chronic effects of weight gain, insulin resistance, and the consequent cardiovascular results are something that we really have to do a better job of. Mark Stringer was one of the, people who was a voice in the wilderness on this in the early days, and recognized that oftentimes what kills patients with, both developmental disabilities and psychiatric disorders, isn't their developmental disability and psychiatric disorder, it's the consequences of the medication which result in these cardiometabolic risks that make them ill, that result in secondary conditions like all of the cardiovascular diseases, including heart attacks and strokes and so forth, which impair quality of life and also can be fatal. So it's very important to think about those in a next kind of layer of thinking about adverse effects. Okay, now there are the serious adverse effects that are reversible, okay? And this is a bigger list that I would want everyone to know about. But the top of the list is delirium. And Susie brought this up during the discussion that medications, and Terry did too, that medications can actually cause memory impairment. Memory impairment is just one aspect of what happens when a medication is disrupting brain and biological metabolism to result in a delirium syndrome. And delirium can look almost like dementia. It can be that bad in terms of memory impairment. But the typical thing for delirium is fluctuation in the level or quality of consciousness or thinking. So if an individual is fluctuating during the day in terms of their level of arousal, their level of alertness, their level of, the quality of their cognition, that is a major warning sign that something is making them delirious. It could be a infection, it could be a biological insult to them of other kinds, or it could be their medications. And delirium is very, very important because it can last for a long, long time. It's totally reversible when you find the source of it, but it can be devilishly difficult to find the source of it. The key is fluctuation over the course of the day in the level or quality of consciousness and cognition. And so that's the thing to think about. Some of our patients fluctuate because they have mood instability. That's not what we're talking about. Fluctuation in mood is a different issue, but fluctuation and sometimes, it can be a little bit difficult to disentangle those. But what we're talking about is level of alertness, quality of consciousness, level of thinking. And so delirium is very, very important thing to put in your category of things that I have to watch for, and that's reversible. Dystonia, we talked about last time, which is a different kind of movement disorder, which is a sudden spasm of muscles, usually involving the face or neck, but can involve your eyes, it can involve any muscle group. And that is, again, very reversible, an adverse effect of the antipsychotics. And then somnolence or oversedation, paradoxical excitation from the benzodiazepines, particularly. We use the benzodiazepines like Valium and clonazepam and Ativan to help calm patients under certain circumstances, but there's some patients that can have paradoxical excitation from them. And obviously that's a huge problem. Hypomania from the antidepressants is always a concern. We use SSRIs like they're going out of style, but what we have to remember is that for all of their benefits and for all of their safety, the SSRIs can cause mania, and you have to be vigilant for the emergence of that. And then our ADHD medicines, the biggest, kind of more serious adverse effects that are reversible are blood pressure changes. And the other, category is just any drug interaction. It's like all bets are off any drug can interact with any other drug, and there are listings of drug interactions that are available online to look for your clients that are on more than one drug. And you can, kind of bone up on that. When you have a patient that's on more than one drug, look up the drug interactions and see if there's anything that looks like that for the client that you're working with. And then finally, there's the nuisance adverse effects that I talked about before: tiredness, dry mouth, constipation, urinary retention. They're not serious, they are reversible, but they can be a real nuisance and they can ruin somebody's day or string of days and quality of life. GI upset is another one. And really, there's adverse nuisance effects, almost any symptom you can think of from all the medications. But I wanted to try to categorize this and make sure that everybody is solid on like the big ticket items that can really get a client in trouble. And then we have more time for the ones that are more nuisances. But of course, all of them are worth treating. All of them are worth paying attention to. So I'll stop there. And if I don't know, Terry, if we have a moment for questions, but these slides will be available to folks, and hopefully that kind of puts things into perspective about how to categorize all the different things that can happen as a result of meds.
Well, we're right at 2:00. But what I'll offer is if anyone does have a question, they can write it in the chat or respond in the survey with those questions, and we can get that information out to the group at a later time. That was very, very helpful and very concerning, John.
Right. Yeah.
Okay, well, thank you all for joining us today. We hope it was at least enjoyable, if not informative. We certainly enjoyed having you all on this session. And Deanna, thank you. And thank you for the work that you're doing.
And let's all take a little encouragement from having the head of the department chime in the way that he did. I think this is a validation to everybody who's on this call, and let's leverage it for hope for the future.
Yep. Okay. And the PowerPoint will be made available to everyone. So,
and Jonathan, yes to licking of lips. You better believe it. Lip licking, it can be a sign of that, and you can pull that out and disentangle on an Ames test, whether that's reversed, that's under the patient's control or not under their control. So definitely be looking for that.
Thank you.
Great. All right. See you next time, or I won't see you next time, but these guys will see you next time, and I'll see you in August.
Take care, everybody. Thanks,
Bye.
Terry. Bye-bye.